What's going on, guys? Tate Talks Medicine here with our Step 2 review series, and today we'll be talking about some high-yield screening guidelines. As a quick preface to this video, I once again wanted to clarify that this content was originally found on the Strudel Medicine channel before being moved over here. So if I mentioned Strudel, that would be why. The Tate Talks Medicine channel will now be your official place to be for board and shelf review, along with other content focused on medical education at the student and resident level. As always, like, comment, subscribe, and let me know what kind of content you guys want to see next. And now, let's get right into it. So first of all, for colorectal cancer, this is straight from the USPSTF, by the way, we want to screen all adults aged 45 to 75. This is important to know. It did used to be 50, but now the new age is 45 to 75. Gold standard test for this will be the colonoscopy, and remember that's every 10 years if it's totally clean. Can be more frequent if there's any sort of risky findings there. Alternatives to colonoscopy include the flexible sigmoidoscopy every 5 years and the Cologuard FIT test every 3 years. Remember the caveat with both of those, if they're positive, your next best step will be a colonoscopy. CT colonography, I also just wanted to mention, it's gaining a little bit of traction. I've been seeing it talked about a little bit more. Very unlikely to be tested, in my opinion. It hasn't really gained any as much traction as um, a universally accepted standard screening test for this. So some high yield considerations, these end up getting tested quite a bit. So in ulcerative colitis patients, we want to screen them 8 to 10 years after their initial diagnosis. And then PSC, if you remember, primary sclerosing cholangitis is associated with UC. You want to do a colonoscopy in those patients at the time of diagnosis. FAP, remember, that's the disease in which they can get early polyps, like thousands and thousands of polyps. You're going to want to screen these patients every 1 to 2 years, starting at 10 to 15 years of age. And then contrast that with HNPCC. Remember, that is Lynch syndrome. You want to screen those patients every 1 to 2 years, starting about 20 to 25 years of age. And remember also with those Lynch syndrome patients, they're also at high risk for endometrial and gastric cancer. So there is some role for screening those patients in the right settings. There's also this consideration for if you have more than two or first degree relatives with colorectal cancer, you'll want to screen at 40, so 5 years earlier, or 10 years prior than that of the earliest age at diagnosis, whichever one comes first. So, for example, if you had two first degree relatives and the earliest relative that had it was diagnosed at 42, you'd maybe want to start screening this patient at 32 and then base your frequency on their risk. So it's very individualized. Less likely that step two would ever make you make that differentiation, but something to consider. Now, our breast cancer, once again from the USPSTF, they recommend screening mammography for women 40 to 74 years of age every 2 years. So we're starting at age 40 every 2 years. You can initiate this earlier if high risk, but once again, this is a very individualized decision. Typically, if you have a positive family history, you can start about 10 years before the earliest diagnosis in the family, similar to what we talked about with colorectal carcinoma. In positive BRCA mutations, an annual breast MRI is recommended from age 25 to 29, and then an MRI plus mammogram after age 30. So that's just a specific caveat for those patients that have a known positive BRCA mutation. And remember, I wanted to put this in there just because it is so high yield. If you're starting from a breast mass, so this obviously wouldn't be screening anymore. Now you actually have a problem, so to speak, in the breast mass. Remember, if you're less than 30 years old, you want to start with a breast ultrasound if suspicious. Remember, if it does look pretty benign, it's an isolated, regular lesion, you can observe with close follow-up, maybe in 4 to 6 weeks, and do an ultrasound if that becomes a persistent breast mass rather than one that might be more migratory. If over 30 years old, remember you want to start with mammography plus or minus the ultrasound. Remember that all has to do with the density of the breast tissue in those age groups. So just to keep that in mind as we go through these. So cervical cancer now. We want to screen women 21 to 29 years of age with cytology every 3 years. Then once you get to 30 to 65 years of age, you have a couple options. You can either stick on that same routine of doing cytology every 3 years, or you can do high risk HPV testing every 5 years, or you can do HPV co-testing, which would include the HPV testing mentioned before and cytology every 5 years. Now, this is a very high yield point, especially on your OB-GYN shelf and especially for your step two exam, because there are those options. And then also noting when can you discontinue this screening. So once you get to 65 or over 65, if you've had two consecutive HPV tests or co-testing procedures done or three consecutive negative cytologies, that would be grounds for saying that you can discontinue your screening process at that point. But once again, remember, all of this is going to be shared decision making once you kind of are deciding, can we stop screening a patient for a disease? And remember, this is also a high yield note. You can do this during pregnancy. So if they're due for a cervical cancer screening in pregnancy, you do not have to wait for them to not be pregnant to do that. You can do this screening test. A lot of times that'll be tested to try to like trip you up and say, oh, should I intervene or do anything in this pregnant patient, or should I just not mess around with it? You can do the screening during pregnancy. So lung cancer from the USPSTF again, we have screening adults aged 50 to 80 years of age with a 20-pack year history and currently smoking or have quit within the last 15 years with a low dose CT scan every year. So an annual low dose CT scan is recommended for these patients. You can discontinue once you no longer fit that rule, which would be meaning you've quit for over 15 years. So once you've passed that threshold, if your CTs have been normal, obviously, and you're not surveilling anything actively, you do not any longer have to screen. But remember also the best way to prevent cancer development, lung cancer development, would be smoking cessation, obviously. Remember, smoking cessation, never a bad answer on one of these tests. But keep in mind that is age 50, and that's with a 20-pack year history. And that's if they're currently smoking or if they've quit, but within the last 15 years. If you get outside that 15 years, you can stop screening. Prostate cancer now. I wanted to make a quick little blurb on this here. So PSA-based screening not routinely recommended by the USPSTF anymore. Remember, this will be largely shared decision making. Different patients might have different preferences in how they want this to be screened. There is just this idea that we were doing so much PSA-based screening, it was leading to a lot of unnecessary workup for prostate cancer, including biopsies, which can have harmful side effects. And especially with how we've been able to treat prostate cancer in some of these patients, there is the argument to be made where it might not be worth screening for, and that's why the USPSTF is not recommending it. However, if you go and look at different specialty organizations, like I believe the American Urologic Society or whatever their governing body is, has recommended some form of PSA screening. But as far as you guys should be concerned, PSA-based screening not routinely recommended. So cardiovascular screening, these are some really high yield ones. So first of all, for the AAA, the abdominal aneurysm, you want to screen men aged 65 to 75 years of age who have ever smoked with a one-time abdominal ultrasound. Remember, this is specifically men. There is also some caveats for women, but the most high yield situation you'll be put in is men aged 65 to 75. You want to do that one-time abdominal ultrasound. Remember the intervention parameters for abdominal aortic aneurysm. That'll be a diameter greater than 5.5 centimeters. Obviously, if you see one with a there, you're going to continue following it. And then remember the also intervention criteria being like greater than 0.5 centimeters of growth within 6 months would also be grounds to go in and intervene on that aneurysm. Hypertension. You want to screen all adults over 18 years of age with office blood pressure measurement. Recall ambulatory measurements to confirm a diagnosis of hypertension prior to starting treatment. And then for hyperlipidemia, you want to screen all adults age 20 to 75 every 4 to 6 years. Less tested on that one just because there is some individual, like when do we go after testing lipids? There's some different individualized risk that needs to be considered when we make those decisions. Metabolic screenings now. The USPSTF recommends for osteoporosis, we want to screen all women 65 years of age or older with a DEXA scan. Remember, you can consider screening younger than 65 based on clinical assessment. There is like the FRAC score, if you've ever heard of that. If you have like a risk of a fracture risk that is high above a certain threshold, it might recommend screening earlier with a DEXA scan to kind of get a hold of that earlier and intervene if we need to. For diabetes, we want to screen all adults age 35 to 70. You can also screen individuals that are younger than that have other comorbidities, such as like overweight or obesity, PCOS, FDR, hypertension, dyslipidemia, a history of gestational diabetes, things like that. Remember your criteria for diagnosis there: a fasting blood glucose greater than 126, an A1C over 6.5%, and then a random blood glucose greater than 200 with any of the typical symptoms, your polyuria, polydipsia, things like that. Infection screening. So I did make a little caveat here. In general, these tests are tailored to an individual's risk factor as to when and how often you do them. So there are some individuals that will be high risk. So look out for our risk factors video. We'll kind of go over some of that at least for different things. But with hepatitis C, HCV, at least one time, adults should get screened 18 to 79 years of age. There's no set interval. That'll depend on individual risk. Likewise, with HIV, at least one test from 15 to 65, no set interval, once again, depending on risk. Now, these actually do become high yield, these next two here. So chlamydia and gonorrhea, an annual screening in sexually active women less than 24 years old. You can keep going if high risk, so past 24 years of old, past 24 years old if high risk, and that would be determined by the behaviors, what they report. Latent TB, if there are risk factors, and this includes us as medical students, as healthcare workers, endemic areas, or immigrants from endemic areas, immunosuppression, things like that, you'd screen with that PPD tuberculin skin test or the IgRA if there's been a prior BCG vaccine. Remember, you can get the BCG vaccine will mess with the PPD TST. So if there are the possible false negative PPD in immunosuppressed states, false positive if they've been BCG vaccinated in the past. So in those patients, IgRA would be the test of choice. But just just keep in mind, once again, this is individualized based on what are their risk factors for tuberculosis. Are they just at risk of being exposed in their occupation, where they're from, or because their immune system doesn't work quite right? So now there's this idea of psychosocial screening. So IPV, or intimate partner violence, we want to screen all women of reproductive age at basically any opportunity to do so. So this is my kind of way of wording it. Really, you always want to be screening for this. Annual exams, new patient establishing care, any admission to the hospital, especially this becomes very high yield in prenatal appointments. The prenatal setting at those patients are at higher risk for this. Anxiety, there's no set interval, but usually this is routine starting as young as 8 per the USPSTF. Remember, in adults, use the GAD 2 or 7. And postpartum, the Edinburgh scale is the preferred screening way for that. Depression, there's once again no set interval in adults, but you should usually look to do this annually in kids over 12. And once again, that's from the USPSTF. Usually this is done with like the PHQ-2, and then if positive, you'd move to the PHQ-9. So then this is the prenatal screening timeline. This is pretty kind of a skeleton for you guys to start memorizing. This is very high yield to know what things are screened at what times. So let's go over it really quick here. So the initial prenatal visit, you're going to look at HIV, hepatitis B, hep C, syphilis, chlamydia or gonorrhea if there's high risk. You want to do a UA and culture because remember, we will treat asymptomatic bacteriuria in a pregnant woman. We want to screen, like I mentioned before, for intimate partner violence, for substance use, anxiety, and depression. We want to do CBC for anemia and look at thrombocytopenia, which can also be just kind of things we see with pregnancy, but to see if we need to intervene. We want to ensure rubella and varicella immunity by checking antibody titers for that, a TSH level, TB if high risk. Remember, you'll also do your RH and antibody testing. That would be done with an indirect Coombs for the antibody testing. And then if they are due, like I mentioned before, you can do a pap smear with cervical cytology if they are due for that during pregnancy. At 24 weeks, this is when we scan or when we begin screening for gestational diabetes. Remember, that's for a one. You start with an oral glucose tolerance test for 1 hour. If it is over 180, that is considered positive. You'd move and make them wait there for until 3 hours, and then you test, and that would be positive if over 140. So those are your thresholds there, 180 and 140. At 28 weeks, we would repeat the RHD testing, like I mentioned before, and you would give RhoGAM at that time. Remember, you'll also give RhoGAM within, I believe, 3 days post-delivery. And then at 35 to 37 weeks, that's when we do our Group B strep swab. Remember, if positive, we would treat with peripartum penicillin. And this also becomes kind of high yield. There's a little bit of some caveats for if they have allergies. So if they have no allergies, you treat with penicillin. If they have a penicillin allergy, if it's minor, you can treat with Ancef or cefazolin. If it's a severe allergy, actually clindamycin is indicated in that circumstance. And then if you have a strain that has been cultured to be clindamycin resistant, you would give vancomycin in that context. So those are kind of your options. Once again, the most common far and away would being peripartum penicillin. So that's the end of this video, guys. Thank you for watching. Once again, always like, comment, and subscribe if this was helpful. And then also some feedback. Was this helpful? Let us know. Give us feedback on these videos, how they're doing for you guys as you go throughout your studies. And then for sure, leave us what topics you want to see next. I'm always looking to see, especially now with the Strudel Bite series, we can make shorter, more focused content on the things that you guys want to see. So keep grinding, keep studying, and we'll see you in the next one.